And alpha-1 antitrypsin deficiency was recognized as producing a slightly different phenotype of COPD, a phenotype that was associated, as you can see on this high-resolution CT scan here, with low-density areas. This is panlobular emphysema, predominantly at the bases, and you can track that from the apex to the base. And that's what everyone thought was the classical case. Now, the more patients you see, the more you realize that the classical case does occur, but there are non-classical cases. And you can see that when we looked at the first several hundred patients on CT scan, we found that something like 1/3 of these patients actually had apical emphysema and looked clinically more like usual COPD patients. And so that's something we actually need to bear in mind. So with that as a background, the NIH set up a longitudinal study looking at lung function in individuals with alpha-1 antitrypsin deficiency, in which they looked initially at what the effect of augmentation or boosting the alpha-1 levels actually had on the decline of FEV1. And so this is the data across mean FEV1 % predicted for individuals, looking at the rate of decline on the vertical axis here, depending on whether they were on a treatment or not on treatment. And when they looked at the whole data set, they found that in this middle region here, there was a separation that was statistically different, suggesting that if you were in that range and on augmentation therapy, your FEV1 decline would be less than if you weren't on augmentation therapy. And that's driven the way we've looked at treating patients with augmentation therapy from then until perhaps more recently. And so I think that we need to be looking at what information we now have in the disease and saying, well, was that right, or is it only partly right? There were some rapid decliners that we had in patients who didn't have COPD, and this was data that we generated by looking at those patients with normal non-COPD spirometry. But when you do a spirometry, you can actually look at mid-expiratory flow rates, and mid-expiratory flow rates are telling you about small airways dysfunction. And so when we looked at individuals with normal lung function who actually had normal small airways tests, and then we followed their decline in FEV1, it's, as a % predicted, pretty much what you would expect. If we had individuals who, despite normal FEV1, FVC ratios, had evidence of small airways dysfunction already, those individuals now subsequently started to show a rapid decline in their FEV1, meaning that we can pick this up really very, very early. And for comparison, here are COPD patients. They've got established COPD, and on average, their decline in FEV1 with the years is about the same as those where all we had to start with was just some small airways dysfunction. So maybe we should be thinking earlier, and maybe we should therefore be making decisions about these individuals earlier before they develop more severe disease. This is an individual patient that was followed, as you can see, from 2005 all the way to 2012 in our group of patients not receiving treatment. And here's their FEV1 as a % predicted. And I think if you look at that, you say the patient's stable. But this is the gas transfer in the same patient over the same period of time, showing a very rapid decline in gas transfer. So although we think, well, gas transfer tells us something about emphysema, FEV1 does, they're telling us different things about the physiological process in the lung. So we have to think of other things than FEV1 when we start to think about how we manage individuals. FEV1 has always been the bugbear of people who've been doing any sort of studies or research within alpha-1 antitrypsin, and perhaps even in usual COPD, because it tells you something, but it's a very poor surrogate of the emphysema process. And this was data that was generated by the European group when we were looking at the RAR gamma agonist as a way of regrowing alveoli. And in the placebo group, we looked at various parameters to say how sensitive are they to change. And so here, for instance, is the SGRQ. It's very insensitive to change. And there's lots of reasons why that will be, and we can discuss them if need be. The FEV1, if it's done really well, would sort of say, well, it is sensitive-ish, to change. But here's a condition of emphysema, and this is gas transfer corrected for alveolar ventilation, and you can see it's much more sensitive to change. But you're looking at emphysema. Emphysema is loss of lung. When you lose lung, the lung gets less dense. And so densitometry, however you analyze CT scan densitometry, is by far the most sensitive way of picking up progression of emphysema in alpha-1 antitrypsin deficiency, which is why it's becoming now used as a clinical endpoint.
So I'm going to talk about the neutrophil in alpha-1 antitrypsin deficiency. And most of us think that the neutrophil is fairly key in the pathogenesis of this condition. So if you look at the general belief is that alpha-1 is produced mainly in the liver and comes out from the liver into the bloodstream and goes into the lung where it protects the lung against proteases. And in alpha-1 antitrypsin deficiency, the Z protein polymerizes in the liver and fails to get out in sufficient quantities into the lung to protect the lung. That's the basic hypothesis. But what does alpha-1 inhibit in the lung? And it inhibits proteases produced by neutrophils. Classically neutrophil elastase, but other proteases are produced as well, such as proteinase 3 and cathepsin G. But the big one we've looked at in the past has been neutrophil elastase, produced in the primary granules of neutrophils. So there's definitely a role for neutrophil elastase in emphysema. This is a neutrophil elastase knockout mouse, and you can see non-smoke exposed wild-type mice over here. And then you can see neutrophil elastase wild-type exposed to cigarette smoke, and neutrophil elastase knockout mice exposed to cigarette smoke, and much less emphysema in a neutrophil elastase knockout mouse exposed to cigarette smoke. So again, neutrophil elastase is important. It's not the only thing, but it is an important protease. However, if you do bronchoalveolar lavage on people with alpha-1 antitrypsin deficiency, you may not find lots of free neutrophil elastase in lavage. In fact, using FRET analysis, we could see free elastase here in this individual, but a lot of the other individuals do not have much in the way of free elastase. That does not surprise us because this is a slow burner of a condition. Intermittently, neutrophil elastase is produced or secreted, and intermittently it causes damage. So there's minimal neutrophil elastase activity in the bile of some Z individuals. However, if you get circulating neutrophils from M individuals and Z alpha-1 antitrypsin deficiency individuals and look for active neutrophil elastase on circulating neutrophils, on the surface of those neutrophils, you can see that M individuals have very little, Z individuals have significant amounts of active neutrophil elastase on their membrane, and Z individuals who get augmentation therapy have significantly reduced active neutrophil elastase on their neutrophil membrane.
There have been these new European Respiratory Society strategic document that's been produced on the management of alpha-1, which is sort of changing the way we think we should be looking at it and managing it. The first thing was how the heck do you measure these patients' alpha-1 antitrypsin? And the simple thing is, well, just measure the level. The problem is that alpha-1 antitrypsin is an acute phase protein, so it will go up and down. So if you're going to do that, you probably should bring in the C-reactive protein with it to see if there's an inflammatory response. Phenotyping is the next common step. That has to be done by a laboratory that actually can do it very, very well. And it may be that we're going to switch now to genotyping because it's becoming much more accessible. The only thing I would tell you about this is that you can't genotype unless you've got the absolute primers. So you have to have the primers for every known defect, or your interpretation of genotyping will be potentially incorrect. So this has to be done by a laboratory that knows what it's doing, and it has to be interpreted by a doctor that knows how to interpret it. Who do you test? Well, you've got your patient, so we're all agreed that you test your patient, and even if someone's told you they got deficiency, I would suggest they should all be checked. Siblings, well, there's a 1 in 4 chance of a sibling having ZZ, so that's why you should check them. There's a 1 in 2 chance of them being MZ, so that's why you should check them. If you get a ZZ as your index case or picked up as a sibling, you manage this patient and follow them very carefully. If you've got a ZZ patient, 2 to 3% of them are going to be married to a heterozygote. And that obviously now has implications for the children. So you should check them earlier rather than later. If you're on this side and you've got an MZ, there is debate. 2 to 3% of the time, they will, of course, marry an MZ. So they may also have a ZZ child, so perhaps you should check that. But there's a debate as to whether one should always do this in every patient and every heterozygote. And potentially the answer is yes. This is a difficult disease. So the patients are phenotypically different. They can have liver disease, they can have renal disease, they can have skin disease as well as their lung disease. Managing them, you very clearly need to have multidisciplinary team meetings. But essentially, wherever you get the patient, the first thing you're going to do is to make sure they understand the genetics. You're going to make sure you understand how it's affected them by some form of quality of life assessment, and then send them off for a series of tests and review them some 3 months later with that baseline data. And then you come up with a management plan. Follow them again, and it may be for a period of 6 months or 12 months or whatever, but sometime during that continuing monitoring, you're going to say, do you still need to go to the MDT meetings, or should we now address augmentation therapy as your option? And so I think all of that has to be done in centers that have got all of the components present, with experts who absolutely understand how wrong you can be when you first think about a patient or see a patient. There have been several studies, and I've put a couple up here. And so this was the first study which was undertaken as a proper aim control study with a placebo and with a treatment arm in it using a marketable product. And so here's the decline in density per year for the patients who are actually on placebo, and here it is on treatment. So we also have the Dutch-Danish study, and so there were patients in that study, and we could put the two studies together. And if you put the two studies together, you essentially got the same data, comparing active versus placebo. And then the RAPID study, which you've probably all heard about now, which was a much greater powered study. And so here, with almost 90 patients in each group, we're seeing almost exactly the same change on placebo, almost exactly the same benefit with augmentation therapy. So all of these studies over the years are showing that, at least in terms of augmentation therapy, lung density is telling us that something is changing with the disease itself. This is the last data that came out of the original RAPID study. The first thing is we're looking at the decline in density of the lung, and the dotted line here is the decline in individuals on placebo. So they're showing a rapid decline in the loss of density. These were the individuals being treated with augmentation therapy. At the end of 2 years, these individuals that were on placebo were now put on to augmentation therapy. And so this linear progression now changes its slope. So there's a very clear and significant change in that slope, and it starts to run almost parallel to the patients who'd have been on treatment all the way along. So this is 2 bits of data from one single experimental clinical trial showing the influence that you've got on this decline in lung density. And this was a study in Germany by Marion Wencker. And so she had patients with alpha-1 antitrypsin deficiency, and she looked at them before and after augmentation therapy itself. So you can see declines in FEV1 here, which are occurring in individuals who've got quite a high FEV1% predicted. So this was the average decline before and after augmentation therapy. If they were in that sort of range that the NIH said we should be treating, again, you can see there's a difference. And when you get down to very low levels, she didn't see anything. But the one thing that's not on that graph is that she had 7 patients who were incredibly rapidly progressing. So they were progressing at a loss of something like 200 mils per year. And what happened in those patients is that on augmentation therapy, that decline absolutely plummeted and went back to a much, much, much lower level. So it would seem that the more rapid these patients were declining, the more likely you were to see a benefit on the thing that's declining.
This patient came to our clinic in the 2007 year. He's a male, 37 years, heavy smoker, current smoker at this time. He smokes, he drinks, and the patient has in a very bad nutrition status. The patient was not aware with his disease, and initially he not want any treatment. This NIACLAS scale was 3. The level of alpha-antitrypsin was 24 milligrams deciliter. Frequent exacerbator and average 1 exacerbation year. This is the CT scan of this patient. Another panlobular emphysema, widespread for all lungs. This is the spirometry. You can see a very, very severe condition of this patient. Very severe spirometry. And we follow this patient once a month to talk with him about the disease, about the severity, the risk of mortality, the treatment, and the possibility to improve or, at minimum, not decrease the pulmonary function at the clinical situation. After 6 months, in 3 months, patient stopped smoking, and after 6 months after stop smoking, we started with Prolastin. 4 years after, the patient has improved a lot. The patient was a member of the Patients of Alpha-Antitrypsin Deficiency Association in Spain, a powerful association. No hospital admissions, only one. In 4 years, one emergency visit for a pulmonary infection, was included in a rehabilitation program. He has a static vesicle at home, and he used it 20 minutes a day, etc., and changed absolutely his lifestyle. In the next years and in the current, at present, the patient is in the same situation. Little loss of pulmonary function, I think that is not significant. 2 hospital admissions in these 7 years only, better linear scale, and he can walk 350 meters nearly. Well, what can learn of this patient? Smoking patient may be subsidiary of treatment if the patient stops smoking, and is, in my opinion, very, very important in this type of patients.